Everything I include on here is like fair game for exam purposes. I have it tailored towards both step one and step two, so we'll make sure to hit on all the step two stuff as well, like the shelf exam and the step two stuff, more so than the step one stuff. So you guys get to choose. And then I won't make you guys be on teams. We'll be one big team. How about that? Okay, P's 200. So I'm gonna let you guys just read the questions yourselves. It's a little bit of a read my mind question. Does anyone know like the name of this specific type of fracture? Yeah, so these fractures in pediatric patients, there's two different types of fractures that we want to look out for, right? One of them is the Greenstick fracture, which we see here, and the other one is like the Torus fracture. So the Greenstick fracture, it's as the name says, imagine you snap like a green tree branch. So the side that's under compression doesn't fail, but the side that's under tension fails. So you can see the cortex is maintained on this side, and then on the opposite side, there's like a disruption of the cortex. Does that make sense? Sometimes they ask about that on, at least from what I've seen on the USMLE stuff. As far as like step two stuff that you should know for this, so these can be treated conservatively just with like close reduction, aka like casting, immobilization. Okay. Yeah, this PowerPoint's pretty cool, huh? Yeah, yeah. So the one that we just saw is called the Greenstick fracture, and then the other one is called a Torus fracture, Torus. And yeah, I think there's a Torus fracture in this slideshow. Yeah. Trauma 400. Yeah, so this is just a clavicular fracture, as you said. You don't need to be too specific about that. So the step two thing that you want to know for this is minimally displaced Pete's fractures, especially in newborns. You don't really need to do anything for. They'll heal on their own. So I think that's like a pretty common thing that they'll give you like a big baby who has some sort of like birth trauma or a difficult delivery, and then they have a clavicular fracture, says, what do you want to do next? And you just say you don't need to do anything for them. Okay. Conservative management. Arthritis 400. You guys are all over the board. I like it. Yeah, this is just osteoarthritis. The things I want you to take away from this one, sometimes they'll give this like question stem and they'll say it resolves like it's worse in the morning, but it resolves in 15 minutes. I think sometimes people see worse in the morning and they think just automatically inflammatory arthritis. Inflammatory arthritis would take like hours to resolve in the morning. It's not going to be like a 15, 20-minute thing. It's normal for people with osteoarthritis to have it worse in the morning just because they haven't really been moving and they get fluid buildup and things like that, and then it quickly resolves. So yeah, gets better with NSAIDs. Don't think that this is inflammatory arthropathy. Another classic lesion or location for OA is going to be the DIPs and then the thumb. Especially the thumb is very classic, whereas rheumatoid arthritis has more proximal like MIP involvement. I'm sure you guys remember that. For step two, they're going to ask you like, what are the first line steps in management? NSAIDs and Tylenol are like the first line medications you should think about. I know there's some confusion about whether it's like Tylenol or NSAIDs. I think the boards technically like you to give Tylenol before you give NSAIDs, especially make sure that they don't have like kidney issues and stuff like that. And then as far as like first line physical therapy, quadricep strengthening program is going to be recommended. And then for refractory cases, you can do like knee replacement, of course. Another thing to notice is this is the fibula, right? So that's going to be lateral. OA oftentimes has this medial predominance, and then you have these osteophytes that start to come off, right? So this is very typical, kind of like an OA look for a knee. Okay, very good. Back pain 200. Very good. So this is a trick question. I'm sorry, I did you like that. So they love to ask this question where they give someone who has, what's the diagnosis here? Yeah, this is like lower back muscle strain. So the thing that they'll say is you want to rule out like red flag symptoms, right? So for like myelopathy, so we don't want them to have like crazy weird reflexes or urinary incontinence or sidle anesthesia or anything like that. Obviously, those point to more serious diagnosis. Palpation over the lumbar paraspinal muscles shows tenderness. Sometimes they'll have like spasms. Sometimes they'll even have some aspect of radiculopathy, aka like pain that goes down into their foot to an extent. As long as they don't really have those red flag symptoms, you're just going to call this like lumbar muscle strain or spasm, and then you don't want to do imaging unless again, the red flags, or if they've had it for 2 months and haven't gotten better. If they have history of like malignancy, something like that, that you could be concerned that they have malignant growth, things like that push you towards imaging. But these kind of clear-cut cases, they'll always try to get you to do imaging, and that's not the right answer. Okay. You're going to go to MR for the most part. MR for spine is definitely preferable for, I think, pretty much all spine diagnoses. The only time that CT is going to be probably better is if you have a trauma or something and you're concerned for spine fracture, then CT will be better. But if you're looking for herniated disc, if you're looking for cancer, if you're looking for infection, so if you have like spinal epidural abscess, MR is going to be better for all of those. Yeah. Yeah, if they have red flag symptoms, I think that's a tough question because in the real world, you just get an X-ray as well. Why not? I feel like on the exams, the answer choice is usually like emergent MR. That's usually going to be like an answer choice. Will they put CT and MRI on there? I don't know. I doubt that. But yeah, usually the answer choice that they give you and you want to pick is emergent MR. Yeah, it's going to be like one of the few times in medicine that you get an emergent MR is for these spine stuff. Any other questions about that? Good questions, guys. Okay. Back pain. We'll continue on the back pain. Paget's disease. I like that you're thinking more systemic though. Okay. So this is one that I would always miss as well. Anytime you see an elevated calcium, I think Paget's disease, I understand why you said elevated calcium. What is the hallmark finding of Paget's disease as far as lab work goes? You're going to have an increased alk phos, right? Yeah, so the alk phos is very specific for Paget's disease. This is actually going to be multiple myeloma, right? Yeah, I know. I used to miss multiple myeloma all the time. And yeah, now anytime I get a question and it has increased calcium on there, I think, okay, is this multiple myeloma? So they have a 4-month history of progressive lower back pain, which is not good to begin with. Abdominal pain, fatigue, those can all be like cancer things and hypercalcemia things. Worse at night and waking him up at night, that's very like cancer specific, honestly, is if the pain gets worse at night, and especially if it's waking you up at night, that's like a red flag symptom, in my opinion. Their calcium is up from the multiple myeloma. And then why is their creatinine up? Do you guys know? This goes back to Benz-Jones protein, remember? So when they have multiple myeloma, they get essentially all these like antibody complexes. So you can think of it almost as a type 3 hypersensitivity reaction type thing, right? Where you get all these like proteins and essentially they just go and clog up the kidney and damage the kidney that way. Next best step for workup on the boards is going to be serum protein electrophoresis. We're looking for monoclonal IgG, right? Bone marrow evaluation and imaging like MR are probably also like reasonable if serum protein electrophoresis is not an option. This is a somewhat common picture that they'll give you on the boards for this type of question. Do you guys see the finding here? So all these little spots that we see on the skull should not be there. Those are all lytic lesions from multiple myeloma, right? So yeah, this is a really bad diagnosis to get. And then I have a little bonus question for you guys. So if I showed you this, let's say it wasn't necessarily skull, but they had sclerotic lesions and it's a male, what type of cancer are you guys thinking of? Yeah, it could be like lower back. Yeah. Let's say I give you like a spine x-ray with sclerotic lesions. Yeah. Yeah, very good. Prostate is the one that has sclerotic lesions for the most part. That's going to be the most common cause. Okay. Very good. This was a good question. Trauma 200. Yeah, this is an ACL tear. I'm gonna try, oh, sorry. Let me see if I can go back one slide. How about that? Yeah, so the ACL is going to be a structure that attaches anteriorly at the medial portion of the tibial plateau, and then it goes to the lateral femoral condyle superiorly, right? So what we should have seen on that MR, I don't think they're going to give you an MR and say what is the diagnosis for ACL tear, but you should see like a jet black structure that traverses that kind of plane like this. In that case, you saw like all the fibers, it was exploded. It looks like spaghetti, honestly, sitting in there. Yeah, gout. What's pushing you to say gout on this one? Yeah, exactly. So those are the tophi. Very good. That's what that's pointing to. I think one thing that you guys should be aware of, the first time I saw gout clinically, I thought it was septic joint. It can be that acute and that painful. But yeah, most likely diagnosis in this person, especially with these non-painful raised lesions, those tophi are going to be pretty pathognomonic for gout. Of course, they have risk factors for it as well. Why do they get gout in their big toe commonly? Do any of you guys know why that's the most common place to get gout? So it's a really cool reason, and once you realize why, it'll make more sense and fit into the disease process for you. So gout is a crystal deposition disease, right? So the crystals, like when you guys did organic chemistry in undergrad, right? When you're trying to precipitate crystals, you make it cold, correct? So the same thing, the big toe is going to be the furthest away from the heart, and it's going to be an area that gets commonly cold. And that's why they get precipitation of these uric acid crystals and gout flares, especially in the toes. So yeah, that's a fun thing. It's a good clinical thing to know as well. Let me see what else I have for you guys. So yeah, risk factors, alcohol use, seafood consumption, meat. They have tophi as well. We talked about the big toe having decreased temperature relative to other things. Can also affect other joints, right? We talked about how it can seem like a septic joint at times. More common in men. So as far as radiological aspects to gout, again, I don't think it's going to be fair for them to show you like a hand x-ray and say, what is the diagnosis here? It's not going to be like that. But sometimes they like give you buzzwords. So yeah, it can be like joint erosion, cartilage loss, joint damage, stuff like that. Those are some of the things that you might see in gout, not super specific to gout. For step one, they want you to know that it's caused by monosodium urate crystals, right? And then they wanted you to know that it was negatively birefringent on parallel light. So it's going to be like yellow needle under parallel light. On step two, they ask you like, how do you treat gout? This is a question that if you go too fast, you can miss it and seem like really kick yourself, right? So what is the treatment for gout? You might think like allopurinol, stuff like that. But remember, that's for chronic treatment of gout. In fact, you don't want to initiate people on allopurinol when they're having an acute gout flare, usually. So there's going to be like two steps of treatment of gout. If they have an acute flare, you want to give them NSAIDs, colchicine, or glucocorticoids. Reasons to avoid NSAIDs, again, CKD, heart failure, you don't want to give them NSAIDs or colchicine. You're going to go straight to prednisone. And then once you have them stabilized, that's when you can do like allopurinol or febuxostat. Okay. Do you guys feel confident? Yeah, so the tophi are essentially just like crystals that have deposited in the soft tissue and they get these like nodules. It can be, and let me pull up some x-rays here. So yeah, you can see some like joint erosion. So you can imagine if they have these crystals that are like within the joint space, it's gonna cause like joint erosions, joint narrowing, stuff like that. If you have them in the soft tissue, they're not like as irritating as from what I understand, and they get like these nodular buildups, but that's basically just also crystal deposition. Okay, sweet. Peds 400. Peds hips. They love these Peds hips questions on the, yeah. Okay. Yeah, so this is going to be SCFE. What clues us into it being SCFE? So BMI is going to be like a big one, right? So usually you're going to have someone who's, I don't know, between age like 9 and early teens, and they're always going to have a pretty increased BMI. So what is the SCFE lesion? It's essentially a growth plate fracture. Sometimes they'll ask you like what type of Salter Harris it is. I would have to think for a second. Is one same? Okay. So yeah, I'm saying it's a Salter Harris one. It's going to present as progressive hip pain, a limp, and again, associated with increased BMI. Certain endocrine disorders can also be associated with it. As far as the imaging goes, so the classic imaging finding is going to be, they call it like ice cream slipped off the cone. So do you see how this hip, relatively normal, right? This hip, you see how it's slipped off? Yeah. Yeah, yeah. The other thing that you can do, these are called Klein's lines, where you can draw these lines aiming down the femur, and it's abnormal on this side. You can see it's slipped off. But yeah, that might be a little bit beyond what you need to know for the boards. Step two, they're going to ask you two things. They're going to say, what type of imaging do you want to get to diagnose this? So the classic answer is X-ray, especially you want to get an AP and then what they call like a frog view lateral. That's going to be like a buzzword for this SCFE lesion, frog view lateral or frog leg lateral. And then treatment, you guys know? Yeah, surgery. What type of surgery? More specific? There's one specific thing that you want to know for this. Yeah, so it's going to be, usually you're not going to use a pin, you're going to use like screw fixation. And the thing that you want to know is that in cases like this, when they have unilateral pathology, you're going to do screw fixation of both sides because they have a really high chance of getting a SCFE lesion contralaterally as well. So anytime you have one, you're going to do the other one kind of preemptively. You're gonna do a preemptive screw fixation of the other side. So yeah, bilateral screw fixation. And you'll see that clinically as well. Questions about that? Yeah, so the things to know for this, again, they're going to have usually a high BMI. You want to get that frog leg lateral view and then screw fixation bilaterally. Or it's 600. Very good. Yeah, supraspinatus muscle, you got very good. Sometimes they'll ask you like which nerve supplies it. On MR, here's the supra muscle, right? And then you can see here's the supratendon. Here's where it should be inserting, and it's torn, right? This is fluid. So this is a supra tear. You should think supra tear when you have someone who has preserved range of motion, right? This person has full range of motion passively, but they have weakness with abduction. The other question they like to ask you sometimes, what does the supra do? It's going to do the first 15 degrees of abduction. And then the nerve is going to be the suprascapular nerve. Okay? So yeah, the supraspinatus and the infra are supplied by the suprascapular nerve, which comes off nerve roots C5, C6. Sounds good? Okay, very good. Those are like the two-part questions where you know the first one and then they just ask you random facts. So you just have to sometimes memorize those random things. But okay. Oh, sorry, I clicked the wrong thing. Maybe no, this is the correct one. This is tumors 200. Yeah, very good. It is osteosarcoma. So let's rewind a little bit and maybe just think of a way to approach this question then. So you're thinking it's cancer because of what category it's in, right? But what else is like making you think it's cancer? Yeah, pain worse at night, progressive kind of insidious pain in like a young kid, not relieved by OT over-the-counter pain medications like NSAIDs, and then they have like deformity as well, right? So these are all going to be things that we don't want to see. And then on X-ray, honestly, this X-ray is fair game. This is like a really bad case of osteosarcoma here. They like to ask you certain things about osteosarcoma, especially the radiological findings of osteosarcoma. So have you guys heard of like the sunburst appearance? Yeah, so sunburst appearance, do you see all these like rays that are coming off? That's the sunburst appearance. So that's just like a testament to how aggressive this cancer is. It's invading outward. And then the other thing that they say is moth-eaten appearance. This is what they're referring to when they say moth-eaten. These are like leaves that are moth-eaten. It just means that there's all these lytic lesions that we see, right? Do you see all these like little tiny specks? And then the last thing that they ask you is Codman's triangle. Do you guys see an example of that? Yeah, this is Codman's triangle. So what Codman's triangle is, it's a type of, they call it like a classified as a periosteal reaction. Imagine you have a tumor growing on the bone and it's growing so fast that it's pushing out on the periosteum and it's tenting the periosteum. So that's why the tumor is pushing and lifting the periosteum off of the bone essentially. So osteosarcoma is a very bad type of cancer to have, very malignant, very aggressive. The other really bad bone cancer is going to be, do you guys know which other one is really bad? It's Ewing sarcoma. Yeah, Ewing sarcoma, osteosarcoma are the ones that you don't want. It has a bimodal distribution, so children commonly. So osteosarcoma. Yeah, so osteosarcoma has a bimodal distribution. The first one is going to be kids, and then the second one is going to be adults, like older adults. And do you know why that is? That's a read my mind question. So the reason that osteosarcoma is more common in older adults is because you can get it secondary to malignant transformation of Paget's disease of bone. Okay, so The folks who get osteosarcoma who are older adults, a lot of times that will be from malignant transformation of Paget's disease. We talked about the radiology. Again, I think the radiology here is actually like somewhat fair yield. I think it's fair games for kind of board exams. So yeah, the sunburst appearance, Codman's triangle, and then moth-eaten appearance. Those are three things to be aware of. And then here is the specimen on like growth pathology. Obviously, this is not the same kid, but you can see these would probably be like the sunburst appearance, right? This is, you can imagine this would be like Codman's triangle, right? Where it's being lifted, the periosteum is being lifted. And yeah, this is bad news bears. Let's talk a little bit about kind of treatment for this kind of stuff. So obviously with the more aggressive lesions and tumors, you need to surgically resect. And then on top of that, you're going to do things like radiation, chemotherapy. Okay. Yeah, this is a bad tumor. You have to be aggressive in treating it. I think this one, especially the imaging, this is like very pathognomonic for osteosarcoma. So I'd say like most likely diagnosis would be osteosarcoma. Would they get a biopsy before they proceed? I'm not sure, honestly. But yeah, probably you could do like biopsy and stuff like that if you need it. Feed 600. Here's the other part of the read my mind question. Yeah. So this is going to be, we talked about the Greenstick fracture. This is going to be the Torus fracture. So the Torus fracture, they also call it like a circumferential buckle fracture. This is going to be a result of, classically, they say like an axial force being applied to a bone. So you can see that it's buckled out or bowed out here. This is like fractured and like almost smushed on top of itself, if that makes sense. Yeah. What to know for part two or step two? Again, you just immobilize these people, cast them, splint them, and they'll do fine. Why do the peds folks get the Greenstick fracture and the Torus fracture, whereas other people don't? It's because their bones are like younger and more malleable. So you can imagine in adults, like they've had like true, probably like more so displaced fracture. In peds, since they have these more malleable bones, they can bend and compress and buckle in ways that it really wouldn't happen in adults. Fair? Sports 800. Yeah, that's not fun, huh? Yeah, exactly. This is the radial nerve. So this is a kind of high yield anatomy thing that they do like to ask on the board exams. So distal humeral fractures, especially with like posterior dislocation of the fragment. So we can see that this is going to be like a spiral fracture. They can go ahead and injure the radial nerve, which courses posterior to the mid shaft of the humerus. Okay. The other question that they sometimes ask you is if you have a more proximal fracture, somewhere up here, like a humeral head fracture or proximal humeral fracture, what type of nerve injury do you likely get from that? That's going to be the axillary nerve. Okay. So axillary is more proximal, radial is more distal, generally. And then, yeah, electric pain shooting, distal, numbness, weakness, these are all bad kind of signs of nerve injury. Very good. Metabolic, 400. Very good. Yeah, we found Paget's disease. Older guy, 70-year-old, headache, pain, progressively getting closer to the TV. This is something you'll sometimes see. So why do they have that? It's because they have like bony growth in the skull and it like occludes their ear canals basically, and they can't hear as well from that. So that's something you'll see sometimes. They sometimes say like their hat size changes. You can also think of growth hormone kind of disorders for that, like hands and feet and head. So if they have a pituitary adenoma and they have like gigantism essentially, increased bone density, cortical thickening, and then elevated alk phos. Paget's disease is the most common cause of an isolated alk phos elevation. Okay. And then we talked about malignant transformation and progression to osteosarcoma as well. So those are all like the high yield things to know for Paget's disease. Here's a case of Paget's disease of the skull. So you can see on the right side of the radiograph, like the right side of the image, probably the patient's left in this case, normal skull, right? And then this is all abnormal skull, right? So what's the issue in Paget's disease? It's like the bone starts turning over like abnormally quickly and thickening and all kinds of odd stuff can happen. We found Paget's disease. Back pain for 1,000. Sorry, the question is cut off. I'll try to summarize what it probably says. So she's seen in the ED 3 days after delivering a baby boy. The delivery was complicated by breech presentation, yeah, epidural anesthesia, and then she had cesarean delivery. She had worsening back pain since the procedure. She's weak when she tries to ambulate. 3 out of 5 strength. And the lower extremity, she's hyperreflexive. Bilaterally, her incision is intact, warm and dry. What's the diagnosis? And then here's imaging. So the next best imaging in this case would have been MR. Sorry. What's the diagnosis here? We have a patient here who underwent spinal anesthesia, right? So they had some sort of spinal procedure, and now they're presenting with, how would you classify their signs as far as their neuro exam? Would you say upper motor or lower motor? Yeah, upper motor because they have hyperreflexia. Very good. So they have myelopathy, right? They have some sort of spinal cord compression, right? We're saying it's myelopathy and not radiculopathy. So myelopathy is the cord itself is compressed. Radiculopathy is like when the nerve roots or the nerves are compressed. So they're having bilateral symptoms. So we're going to call this myelopathy. So this is going to be a hematoma, like a spinal epidural hematoma as a result of spinal epidural anesthesia causing myelopathy. So yeah, a lot of dots to connect for this one. Other things that you could have that are going to be similar. If they had a fever, what would you say this is? Yeah, spinal epidural abscess. And then the other thing that they'll give you sometimes is the answer choice to throw you off. They'll say, is this like a high spinal? AKA like did their spinal anesthesia go too high and now they have this kind of weakness and stuff. The time frame for this doesn't fit, right? They're like 3 days out. They've started to develop new symptoms. If you gave them anesthesia and they start having like difficulty maybe breathing or different types of like weakness, you could look into high spinal type stuff. But yeah, this is not going to be a high spinal. Questions? Okay. Yeah, so you had someone with air embolism and then they had spinal symptoms. Yeah, I'm not 100% sure. It's difficult to say without having the question. I think one of the things, if it's from epidural anesthesia, it could be that they got into somewhere they weren't supposed to go. I feel like the question that you see a lot of times if they have an aortic surgery or some sort of cardiac surgery, and then they have paralysis after, and they want you to know that they've knocked out it's called like the artery of Adamkowitz. Have you heard about that one? So these are like small feeder branches that go off the aorta directly. So if they have like aortic dissection or if they have some sort of aortic surgery, sometimes you can have iatrogenic injury of the artery of Adamkowitz and you can get infarction of the cord. I assume it might be something similar to that where like they've introduced air into the vasculature somehow and have given them an air embolism. But again, I'm not 100% sure. That's going to be like a very niche thing, right? Yeah, yeah. Okay, are we good with this question? Sorry that the animation wasn't working properly. Oh, oops. We gave you a sneak peek of the next one. Okay, very good. I like that. My OCD was kicking in just seeing that floating around. Yeah. Okay, not rheumatoid. It is inflammatory. So you're thinking it's inflammatory, right? And why are we thinking they have like pain and stiffness in their hands that last several hours, swelling, right? And then there's some kind of high yield associations to figure out what type of inflammatory arthropathy this is. So the X-ray is subtle. Don't look at the bones, more so look at the soft tissue. You see how big and swollen this finger is? Yeah, so what's the buzzword for that? They call it like sausage finger, right? And then what do we have on the nail? Do you guys see these little pits? Yeah, so if I say like inflammatory arthropathy, pitting of the nails, sausage finger, which one of the inflammatory arthropathies do you think about? Okay, okay, no worries. So this is going to be psoriatic arthritis. Yeah, so psoriatic arthritis, think of like psoriasis, like skin psoriasis, like plaque, stuff like that. Pitting of the nails is going to be like a relatively specific thing that they might test you on, a specific association, pitting of the nails. And then the sausage finger deformity, especially with this like hand arthritis. Yeah, that's going to be the picture for psoriatic arthritis. So yeah, there's all these different. No, go ahead. So if they're going to try to give you someone who has a diagnosis of psoriatic arthritis, they'll probably have some sort of derm finding like psoriasis, pitting of the nails. The sausage finger is also really common. Not 100% sure like how common the association is for them to have like true psoriasis. I would assume they probably would. I think just the pitting of the nails is really specific, honestly. So I think even without the psoriasis, it's like the pitting of the nails should be almost like a more specific clue in a way. Yeah, some of these questions are just like you've either seen it or you haven't seen it. And then once you see it and you just stash it in your brain, the next time you see it, you'll recognize, right? So next time you have a question and they have a sausage finger, they have some sort of derm thing, or maybe their nails are messed up and they have inflammatory arthritis of the hands, you'll think psoriatic arthritis. Okay, very good. Psoriatic arthritis. I think with most of these, you start with like prednisone and stuff like that, and then work your way up to biologics as needed. Yeah. The one exception to that is going to be ankylosing spondylitis, at least from what I know. Tumor is 400. I'll accept the diagnosis from you guys. Okay, let's back up a little bit. Would you guys categorize this as like an aggressive or more benign type of bone lesion? So they have 2 months of persistent pain, tenderness and palpation. Sorry, it shouldn't be femur, it should be humerus. So yeah, persistent pain in the right upper extremity, tenderness, palpation of the proximal humerus. So they have a large lesion, onion skin periosteal reaction. So anytime you have a periosteal reaction, it's going to be like a more quickly moving process by definition. And then they have soft tissue extension as well, right? So they have some sort of invasion of the soft tissue. So that's going to be an aggressive type of tumor. They have high N to C, as you said, which again kind of points to the fact that it's rapidly dividing and aggressive. So what's the diagnosis here? It's going to be Ewing sarcoma. Yeah. And what causes Ewing sarcoma? That's going to be the 1122 translocation. I don't know if you remember that one. I always remember it. It might not be as helpful for you guys. If you're into basketball, Patrick Ewing was number 33, and it's 112233. Probably not super helpful for you guys if you don't watch basketball, but yeah, you have to be up on your like 90s New York Knicks basketball trivia to get that one. So yeah, we talked about all the things that point to this being an aggressive lesion. Onion skin periosteal reaction. It's a buzzword, but what does it look like? Do you guys see here? You see this kind of layer and then another layer? So what that is that. So the tumor is growing underneath, and then the periosteum like kind of calcifies, the tumor grows, the periosteum calcifies. So it's just pointing to the fact that the periosteum doesn't have time to calcify wholly, right? Calcify grows. The tumor is pushing on the periosteum too quickly for it to calcify in time. So that's the onion skin periosteal reaction. Where does the tumor occur? Technically any bone, but often long bones in the pelvis. Again, this is another one that's highly aggressive. It can metastasize to other parts of the body, especially the lung. What do you guys think the treatment would be based on what we've talked about? Yeah, so some sort of surgical resection and then plus or minus chemotherapy radiation, right? So osteosarcoma and Ewing sarcoma, these are going to be, again, very aggressive tumors. So we need to get rid of them, one, so surgical resection, A, and then B, the big guns, chemotherapy or radiation as far as treating these go. Fair? Okay. 1,000. I like it. You're thinking big. The USMLE has these military questions that are like part of it now. So this is a good one. I'm very proud of myself for my PowerPoint, as you may have figured out. Yeah, it's fun, huh? Oh yeah, no, of course. Where are you looking? Are you looking here? This one? Yeah, so this is gonna be normal. This is like what they call like I think they call it like a bipartite sesamoid or something. So essentially there's like a sesamoid bone underneath the big toe, and sometimes it's two-parted like this. Yeah, this stuff here. Yeah, very good. So that's the finding. This is a subtle one. They probably wouldn't show you the X-ray here. Based on just the clinical picture here, it should usually be enough to clue you in to what the diagnosis is. This is going to be a stress fracture. Okay. So what are the risk factors for a stress fracture? They're low BMI, right? 18.5 BMI. They're doing like basic training, so they're probably like rucking and carrying weights and running, especially like an acute increase in activity. If I gave you someone who's like low BMI and started training for a marathon suddenly, or like someone who's a military recruit, this is going to be a very common presentation for this. The other thing is there's point tenderness at the dorsum of the foot. I think anytime you see like bony point tenderness, think fracture, right? So if I give you someone who had like a car accident and they have C-spine point tenderness, think like they have a C-spine fracture. right? What did you see on the X-ray? Do you see this thin line here? Very subtle. Okay, it might just be difficult depending on how the screen, but there's a really subtle fracture here. Honestly, that is much more difficult to see than you can see this, right? That's callus formation from the fracture. Yeah, that's like early callus formation from the fracture. Yeah, it's going to be more so like progressive, right? Because they're going to have this insidious fracture. It's not like a it's not like an acute fracture where it is fractured. It's like a weird thing, right? Because it's like it is fractured and then they keep walking on it and doing their activity, which kind of makes the pain worse and worse. Yeah. Yeah, these stress fractures are going to have kind of an insidious onset, which can sometimes be tricky. Treatment for this, you want to go after the root cause. Yeah, rest. Offloading and rest are going to be the things that you want to do. Sometimes they'll say like physical therapy. That's not the answer, right? You want to just offload them. The reason that they're having this issue is because they're putting too much force through the bones and the bones can't quite handle it yet. So the treatment is to reduce that force or remove that force as much as possible. Surgical management, sometimes you need to manage these surgically, especially there's like certain types of fractures that you need to know. The Jones fracture is one of them. So the Jones fracture is like a fifth MCP tarsal fracture. Usually, I think it's more like proximal. Don't quote me on that. Essentially, the issue with the Jones fracture is it's in a relatively avascular zone. So when you fracture in that area, it doesn't heal properly, usually without surgery. But for this case, yeah, offload them, analgesia, rest. Sounds good? Let me see how we're doing on time. I think we should be all right. I'll talk a little bit quicker too. P's 800, more hips. Yeah, so these are tricky questions. You've taken a lot of tricky ones. This is not septic arthritis. Yeah. So this is the one that I don't know how to pronounce either, Mara. It makes you feel like very, yeah, I think it's Legg-Calvé-Perthes disease, LCP. This question was tricky because I included febrile illness 2 weeks ago, which sometimes can be like lead to septic arthritis or transient synovitis. We'll talk about some of that stuff in a little bit. So what is LCP? Childhood condition where the blood supply of the femoral head is disrupted. Essentially, this is going to be like avascular necrosis in a child. Okay. I'm not like 100% the same, but for the most part, that's basically what it is. As far as the imaging goes, do we see on this side, obviously, like they haven't calcified their growth plates and stuff, and this femur doesn't look like an adult femur. You see how this one is relatively, we're going to call this the normal side. And then here it's like widened and smushed and doesn't look quite right. That's going to be like the avascular necrosis and collapse of the femoral head. Okay. They're going to have hip pain, stiffness, limping, treatment. You're going to rest, brace, physical therapy, and in severe cases, you might need surgery. How do we differentiate this from similar pathology? So these peds hip arthritises are just, they're really similar, honestly, and it's really difficult to differentiate them sometimes. So let's talk about our differential diagnosis. We said they had febrile illness like 2 weeks ago. Sometimes they can get what's known as transient synovitis. Have you seen any questions with that yet? Yeah, so transient synovitis is going to be, exactly what it sounds like. They essentially get like inflammation, synovitis of the hips. This is usually going to be like bilateral though, not unilateral. Okay. SCFE we saw earlier. On SCFE, we wouldn't have flattening, we'd have it being slipped off, remember? And the other thing is usually the BMI is going to be a big giveaway. I guess I didn't give you guys a BMI on this one, but we can assume that it was normal for this case. Usually they'll tell you like patient is 95 percentile BMI or 99th percentile BMI for SCFE. Septic joint, what would we have in septic joint? They'll usually give us like fever, ESR, CRP increase, right? The inflammatory markers, stuff like that. But yeah, these definitely can be tricky, and this was a tough question, but a good review, I think. Yeah. So what would the diagnosis be? Yeah, read my mind type thing. Yeah, very good. So this is gonna be like non-accidental trauma. This is a motif or question stem that you guys will probably see, honestly. So they'll try to a lot of times paint the parents as being irresponsible, not to be judgmental. Yeah, not, but they'll say things like, they had STI in pregnancy. They'll say like their first time parents. They'll say the mom is like 18 or 20 or like something young. Again, I'm not trying to be judgmental, but these are kind of things that they'll put in the question stem. The other thing is, do 8-month-olds walk and jump and run? They don't do any of that kind of stuff yet. Yeah. So there's going to be like an inconsistency in the story where it's like a kid should not be running and jumping at 8 months. And then the other thing is this fracture is going to be like a spiral fracture. You're not going to really see those unless there's been some like pretty significant amount of force applied. Let's talk about kind of other stuff related to this case though. So they have a spiral fracture of the femur. That's when you have a rotational force applied to the bone. You will see sometimes a spiral fracture of the tibia. That's going to be called a toddler's fracture, and it may be normal in children who are ambulatory. Okay? This kid is not ambulatory. They're not running, they're not jumping, they're not walking. They shouldn't have any sort of like fracture from jumping off the bed, right? We talked about like them being 20. Delayed presentation to healthcare professionals, another one, right? So they've had this for a week and they haven't come in. And then again, inconsistencies in the histories. Other things that are associated with non-accidental trauma. Can you guys name any of the buzzwords? I have them here. I'll go through them, of course. But sorry, I like to ask questions. And yeah, that's a good one. When they have a sharply demarcated line, especially sparing of the flexural surfaces. Yeah. Have you heard of that one yet? Yeah. So they'll have a sharply demarcated line where they're burnt. If you look it up, it's like essentially they like dip the kids in like really hot water and then the kids will like contract, so they'll spare the flexural surfaces, right? Because they'll put their knees to their stomach, so like the back of their knees won't be burnt, like the front of their hip creases won't be burnt because those are going to be spared from burning water. Other things to look for on the boards: retinal hemorrhage, subdural bleeding, which can be really, I won't get into it. It can be really subtle for the radiologist to pick up, honestly. Subdural bleeding, retinal hemorrhage, metaphyseal corner fractures is another common one that you'll see. Rib fractures, and then like weird parental oddities that they'll try to paint the parents as being like irresponsible, essentially. Other things that can have similar presentation: osteogenesis imperfecta, right? You can have like kids who have unexplained fractures. That's going to be a mutation in, do you guys remember which protein? Collagen, I think it's collagen 1. So it's going to lead to brittle bones. Other things that you get: hearing loss, blue sclera. Do you guys remember the blue sclera? So the reason they have blue sclera is because when they have collagen loss, the sclera are thin and you can see the vasculature of the veins behind it. So that's why you get blue sclera. Other things, this is not like super related, but sometimes you can have like hemarthroses due to hemophilia, sickle cell pain crises. These are going to be reasons that you can have some MSK complaints, not necessarily fracture in like pretty much young or newborn kids, 8-month-old. So in this case, like a pretty young toddler. Any questions regarding this one? Back pain 600. This is going to be one of those like triad, recognize the symptoms type questions. Yeah, very good. Bamboo spine. So there's bamboo spine right there on the right side. This is going to be ankylosing spondylitis. So I think you identified that they had inflammatory back pain, correct? We differentiated that from like degenerative or like osteoarthritic back pain. And then they have several features that are very commonly associated with ankylosing spondylitis. So they have sacroiliitis, SI joint inflammation, enthesitis, which means like where the tendons attach to the bones, they have inflammation, and spondylitis as well. X-rays, ossification of the intervertebral discs. So you can see these guys right here. These should not be ossified. You can see that the spine is continuous, right? Honestly, for some reason, if you have like inflammatory back pain and it's like a 20-something or 30-something-year-old male, your brain should just automatically jump to this. Like honestly, anytime I saw a question stemmed by the end of dedicated and it said like you have a 28-year-old male who comes in with back pain, I was just like, okay, this is 95% going to be ankylosing spondylitis. That's just the demographic that it usually, yeah, uveitis is also associated with ankylosing spondylitis. Yeah. So things to know about this: HLA B27. Do you guys remember that one? So HLA-B27 subtype, a young men 25 to I would say like maximum 40, but usually in like their late 20s, so like my age. First line treatment is NSAIDs, and then you're gonna progress to things like TNF alpha based medications. This is the one that we talked about a little bit earlier. So this is not respondent to steroids for some reason. I'm not 100% sure why, but yeah, don't give them like prednisone. Start with like NSAIDs, and then after you go to TNF alpha blockers. Fair? Okay. Back pain, 800. Yes. So this is going to be abscess, or I'm going to nitpick you a little bit here. So you're on the right path, definitely. What do we see with abscess? Like you're gonna have neurodeficits, right? Like you're gonna have like myelopathy, right? So does this person have myelopathy? So this is gonna be discitis, osteomyelitis, right? Sorry, I'm being really nitpicky, but do you see here all this kind of increased signal? So that's going to be the infection. We're saying like this person doesn't have at least an abscess that's large enough to be like compressive in this case, but they have this focal tenderness. They have all these signs that point to infection. Why do they have this kind of new murmur? Yeah, exactly. Infective endocarditis. Very good. Yeah, let me just run through this real quick. IV drug use with malaise, fever, tricuspid murmur, night sweats, new onset back pain, focal tenderness. This should be discitis, osteomyelitis. You said abscess. I give you credit for it, but I think sometimes it's good also to try to tease out the differences between some of these pathology because that's what the boards will ask about too. Honestly, they are nitpicky. Tricuspid endocarditis is highly specific to endo or IV drug use. Do you guys know why it is? This is another interesting one. So the reason that they get tricuspid endocarditis is due to mechanical abrasion and bacterial seeding of the valve by drug contaminants. So you have drugs, you're injecting them venously, right? Hopefully they're not doing like an A line to inject drugs, but you're having venous injection of the drugs and they have like actual particulate in them. So what's the first valve that they see is going to be the tricuspid valve. And actually you have like essentially like dirt and debris that will abrade the valve, and then also all the bacteria and stuff that you're injecting into yourself. That's the first valve that they see. So that's why you get tricuspid endocarditis, which is I think pretty interesting. And also now you guys will never forget that it's going to be the tricuspid valve, right? You'll just say, oh, which valve is the first one that all the blood will see when it comes back to the heart. Most common bug, Staph aureus. How do you diagnose it? Tricuspid endocarditis. Echo, yeah, very good. Blood cultures first, and then antibiotics. So yeah, don't give them antibiotics until you can get blood cultures. And then cover MRSA. We talked about discitis, osteomyelitis, back pain, plus or minus myelopathy. So in this case, minus myelopathy, depending on the presence of concomitant abscess. The radiological features we won't necessarily get into, but just notice that they have this disc doesn't look happy, right? It should be looking like the other discs. Here are some other normal discs, and these bones don't look happy, right? That's the kind of MR findings to find. Arthritis 600. Oh, this is one of my favorite questions. This is like the guy on the USMLE boards who has every single risk factor possible. He like goes to Africa, gets bit by mosquitoes, swims in a lake, eats like raw zebra meat, does whatever you could ever imagine. Yeah. X-ray, what are you going with? Okay, so what's on your guy's differential? Okay, okay, fair. What about gout? He has risk factors for gout, right? He lives in New England and runs around the woods, so it could be like Lyme, right? So honestly, the point of this question is anytime you have a knee that's swollen, erythematous, and has decreased range of motion, you need to tap that joint, right? Because this could be septic arthritis. It could also be gout. It could be Lyme. It could be septic arthritis due to Neisseria. Let's not even worry about what it is. Um, you need to tap the joint. And sometimes they'll say, okay, this person has a history of gout. They're coming in with, or they have all these risk factors for gout. They're 65 years old. They drink beer. They eat only shrimp and red meat. That's their like only the thing that they eat for their diet. And they'll say, what do you want to do next? And you might be like, okay, this person has gout. I want to give them NSAIDs. They could also have a septic joint, and you need to rule it out. And also for gout, how do we diagnose gout? It's not a clinical diagnosis, right? We're going to get synovial fluid and then look at it under microscopy to find crystals, correct? So yeah, don't get too tripped up by this. If it can be a septic joint, you generally want to tap it. And they'll try to convince you that you don't need to, but you do. Okay? Most common bugs, Staph aureus, atypical bugs. You get them in people who are like diabetic, if they have prosthesis, like a joint replacement, if they have splenectomy, if they're functionally asplenic, you can get different bugs, right? So I think like diabetics, they can get like Pseudomonas, prosthetic joints, they get conus, coagulase negative staph species. So essentially staph epididymis. Splenectomy, people can get weird encapsulated stuff, right? Salmonella is the one. Okay, very good. I think we'll see this guy again. In real life, it's you would probably just get an X-ray, right? Because why wouldn't you? For the boards, you want to know the next best step is going to be arthrocentesis. And in cases of septic joint, it's both diagnostic and therapeutic, right? Because you need to get that stuff out of the joint one way or another. Should we do arthritis 800? Maybe our friend will pop back up again. I'm not sure. Oh, no, it isn't. He's in the next question. I can see what the next question is. You have to do one more hand arthritis one first, and then we'll see our friend again. Yeah. No, it would be an uncommon place for you to get like osteosarcoma. Yeah, this is going to be rheumatoid. So the first step is to differentiate between inflammatory and non-inflammatory arthropathy, right? This person has like bilateral stiffness of the hands, right? I guess I didn't specify bilateral. I said stiffness of the hands. Worse in the morning, resolves throughout the day. Worse at the proximal MCPs. And then she has some osteopenia and erosions. The erosions you can see like here, joint erosion. It's like all over. But you don't need to worry too much about that. You're not a radiologist, and neither am I. So we said that this is an inflammatory arthropathy. What type of inflammatory arthropathy is it going to be? This is more so pointing to rheumatoid thing. So what else do we get? Boutonniere deformity and swan neck deformity. Have you guys heard of that one? They have a predilection for the MCPs and the carpal bones. So more proximal sometimes here, and then the carpal bones. Whereas osteoarthritis, mostly DIPs, distal, and then base of the thumb here. This is really common. And you'll see this like in older patients in the clinics, just normal people. If you look at their hands, you'll see a lot of times they have a big nodule here. That's osteoarthritis of the hand. Rheumatoid arthritis can have lots of different manifestations systemically. One really common one is like effusion. So if they have like pleural effusion or pericardial effusion, that can commonly be due to rheumatoid arthritis. Make sure you guys touch up on like reading about RA before your exams because it really can show up in a lot of different ways. What serological tests are associated with RA? This might be more of a step one thing. Anti-CCP is more specific. Rheumatoid factor is more sensitive. Methotrexate is the treatment for it. There's lots of different side effects of methotrexate, cytopenias, macrocytic anemias due to the effect on folate. Hepatotoxicity, not good for babies, again, due to folate. So know all of that. Other things, I'm slamming you guys with information right now about RA. Sorry, honestly, this hopefully will be a little bit of a refresher, and then a lot of stuff you'll probably have to look into. Atlantoaxial joint instability is another commonly tested thing. It's also associated with Down syndrome, but RA as well. Sometimes they'll ask you, you have a patient with RA and they need pre-op clearance. What do you want to do? The answer for that question is going to be C-spine X-rays in flexion and extension. This test for atlantoaxial instability. Sometimes they'll even give you like CT of the C-spine as an option. And you have to know, like for atlantoaxial instability, C-spine X-rays and flexion and extension are what you want to get. CT is not going to give you the information you need. Other things to know, when you start methotrexate, you want to get baseline labs. You want to get like liver function testing because you can have hepatotoxicity. Yeah, sorry. Slammed you guys with information on this one. There's a lot to know about, probably more than I could realistically cover. Should we see our friend again now? Familiar face. Okay. Yeah, very good. So this is gonococcal arthritis. Very good. This is again one of those recognize the triad type thing. What is the thing about gonococcal arthritis that makes it hard is it comes in two flavors. Okay. One of them is this very pathognomonic one that we see here. It's going to be like a triad of polytenosynovitis. So what is tenosynovitis? It means like the sheath around the tendons is inflamed. Tenosynovitis. And then a pustular rash. That's like a very pathognomonic thing. If they have tenosynovitis, polyarthritis, and a pustular rash, that's home run, slam dunk, disseminated gonococcal infection, aka in this case, gonococcal arthritis. You can also have monoarthritis, which you'll have a septic joint and a negative gram stain. Why do you have a negative gram stain? Step one correlation. Where does gonorrhea? Yeah, gonorrhea is intracellular. It lives in, I want to say, macrophage. Is that correct? Yeah. So you have a negative gram stain. What do you have to do in that case? And this is a question that I've seen on the boards, not necessarily like on the boards, but on boards reviews kind of material. For gonorrhea, you're gonna do NAAT. Yeah, yeah. So you need to like if I have someone who has this picture, like young guy, septic arthritis, monoarthritis, risk factors for gonorrhea, we tap him. It's not like one of the expected things for septic joint, like AKA it's not like Staph aureus or something like that. And we're saying like, what is it? NAAT to make sure it's not gonorrhea. Okay. Da, 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 da. And then the other thing is this person has every single rash or sorry, risk factor possible. You really need to have a good feel for interpretation of the physical exam, as well as the things that differentiate between different types of pathology. So for example, if I gave you the same picture and I said he has a maculopapular rash, which includes his palms and his soles, what would you think? It could be like syphilis, right? Yeah. If I told you had heart block or facial palsy, what would you think? Yeah, Lyme disease. So when you get questions like this, make sure you go through the other answer choices to see what differentiates between this and Lyme disease and septic joint and stuff like that, because that's where the money is going to be, right? Okay, we have 6 questions left. We're coming up on an hour and a half, so I'll try to be even quicker. Sorry, guys. Metabolic. Oh, sorry. I clicked tumor 600, you said. Yeah. This is either you know it or you don't type thing based on the X-ray. That's fine. We'll give you a little bit of grace then, Mara. Okay, so this is what they call like a pedunculated. What does pedunculated mean? Peduncle means it's like on a stalk, right? So I have this thin little thing, and then it's this big thing. This is like a pedunculated lesion of bone in a younger kid, painless bump. This is going to be osteochondroma. Yeah, either you know it or you don't. And now that you've seen it, you'll see it and you'll know what it is. Pedunculated bony lesion from the metaphysis of the femur, usually from the metaphysis of the long bones. It's pedunculated with a cartilage cap. They are asymptomatic, but they can cause compression of adjacent structures. So treatment, you're going to treat this conservatively. It's not like an aggressive lesion that needs to be removed and chemotherapy and stuff like that. You're going to just manage it as conservatively as you can. If they have issues from like nerve injury or vascular injury, just from the size of the lesion, then you can look into surgery. Okay? They can also undergo malignant transformation sometimes. Not as bad as, yeah, I guess it depends like how their symptoms are. If they just have a weird growth and they come and they get it checked out, you might want to just see them every once in a while. If they have like true issues from it, you probably see them more often. I'm not 100% sure about that though, to be quite honest with you. Honestly, any sort of kid with a bone lesion, usually they'll just bring them back for serial x-rays like every couple months, from what I've seen in radiology. But I haven't been in the clinical setting where they've talked about that. All right, metabolic disease 600 you wanted, Mara? Sorry, I'll give you what you want. You got the answer correct. Yeah. I'll tell you guys a little about the radiology after. It's not super high yield to know, but I just thought I'd include it. And this was originally for radiology. I run the radiology certificate program at my school, so that's why there's so much radiology on this. So yeah, rickets, this is going to be due to which vitamin deficiency? Yeah, very good. Failure of bone mineralization. That's the ultimate pathophysiology is you fail to mineralize bone. So they have soft, weak bones causing deformities such as bow legs, knock knees. Other things that you can see is beading, right? There are palpable protuberances along the anterior chest. What's the fancy term for that? The doctor term? Rachitic rosary. Have you heard that term before? Rachitic rosary. So it refers to like rosary beads, like the prayer beads. So it's almost as if they have those like along the anterior chest because they have this failure to ossify at the like sternocostal for where their ribs meet the sternum and they get like these kind of palpable protuberances. Um, so yeah, that's rachitic rosary. Maybe that was what was on your test, but they had a fracture, right? And then they had, yeah, so this is different. Another thing is soft skull. Do you know the fancy word for that? Craniotabes is what they call it. That's like the fancy doctor term. Craniotabes and rachitic rosary. Those are two things that not super high yield, but sometimes you'll see them. Radiological aspects. They fail to mineralize their bone, their growth plates, correct? They get widening of the growth plate, fraying of the metaphysis, cupping, which means it's just splayed out, and yeah, splaying. And again, these are just all as a result of a failure to mineralize the growth plate. Does that make sense? Yeah. So the reason if you just think about it, okay, they can't mineralize their growth plate, so they're going to have the metaphysis is going to be like partially calcified, aka fraying. Their growth plate's going to be widened. They're going to have cupping and splaying. Almost done. Four left. You guys are at the finish line. Tumors. All right, we'll blast tumors real quick. This is another one, kind of you either know it or you don't. Give away the diagnosis to an extent with the biopsy. So this is giant, huh? Yeah, giant cell tumor. Yeah, I feel like bone tumors are something that medical schools don't usually cover super well, honestly. So I don't blame you guys for not knowing a lot of these. But after this talk, I think you'll have a good approach to some of these bone tumors. So giant cell tumor is benign, but it's locally aggressive, right? So you can see that there's this like big lytic area. Obviously, that can have its own issues, but it's not going to metastasize and cause cancer in other places. Most commonly around the knee, you'll see a lytic lesion with well-defined margins and thinning of the cortex. The kind of classic buzz term is like soap bubble appearance. They'll say it's like a soap bubble appearance. They'll have pain, swelling, decreased range of motion. The tumor has a high rate of recurrence. This is going to be an exception to the rule as far as what we operate on and what we don't. So benign lesions we don't usually operate on because this is like locally aggressive. We do operate on this. So the first option is like curettage or resection. And then you can also do things like denosumab, which is a monoclonal antibody against rank L. You sometimes see that for the treatment of osteoporosis. That can also be used sometimes. Treatment of these is not super high yield, honestly. I don't think you'll get questions. Maybe you'll get like one or two throughout your whole board prep if you do enough questions, but that's the giant cell tumor. And then we'll do tumors for 1,000. Here's the finding. I'm sure you guys might have clued in on it. Okay, so this is osteoid osteoma. This is, have you heard about this one at all before? Yeah, yeah. Honestly, they're hard to remember and hard to differentiate, so I don't really blame you, man. Osteoid osteoma, it's gonna produce like night pain in a 16 to high school to college age kid, basically. I think it's usually a boy. It produces pain that's unrelated to activity. It's classically relieved by NSAIDs, which differentiates it from other tumors, mainly osteoma, I think. I think osteoid osteoma and then osteoma are like basically very similar, small round lytic lesion with pain plus or minus on whether it's relieved by NSAID. And that's going to be the differentiating factor between the osteoma and the other version of osteoma. And kind of a quick review. I know a lot of the people at my school are not good with their bone tumors either. I think just doing this one time and seeing them, like next time you're doing practice questions and you see a bone tumor, oh, I remember this like weird pedunculated thing that sticks off, like which one was it? Chondroma, sarcoma, and it'll plant the seeds for you guys, hopefully. Metabolic 800? Oh, this is like one of those super low yield associations that USMLE loves to test you on for some reason. So what's the X-ray showing? So those are going to be chondrocalcinosis, right? So here's the bony cortex. So in between is cartilage, right? It's not just like floating with air. There's cartilage in there that we don't really see, but we see this calcification of the cartilage. This is pseudogout. This is a really annoying question until you've seen it like once or twice, and then you'll never get it wrong. So it's caused by the deposition of calcium pyrophosphate crystals in the joint space. Typically affects the knee. Can also affect other joints like wrist, shoulder, ankle. Common in older adults and has some comorbid conditions that it's associated with. One of them is hyperparathyroidism, and one of them is hemochromatosis. We won't talk about bifringency on light because it's not super relevant to us, but synovial calcification and chondrocalcinosis are really commonly tested findings with pseudogout. You treat it similar to gout. So we said that you want to do like NSAIDs or colchicine first, glucocorticoids if they have CKD or heart failure. Fair? Yeah. So when they give you this like acute knee pain and then chondrocalcinosis, thinks gout. Yeah. Annoying. Sorry. I don't write the tests. I just try to prepare you for them, I promise. Yeah. Yeah, very good. So osteoporosis, DEXA scan. This is how the results of a DEXA scan look like. It's basically like one big X-ray. There's not much radiation from a DEXA scan in case you ever have a patient ask you that. But yeah, low bone mass, structural deterioration of bone tissue, increased risk for fracture, commonly in postmenopausal women due to decreased levels of estrogen, right? Estrogen is protective of bone health. Screening for osteoporosis. Do you remember who we screened? Yeah, very good. Maybe. I'm not 100% sure. I think if they're like 65 or older, and then honestly, yeah, probably if they have risk factors, it's fair to screen them, especially if they have some sort of insufficiency fracture. That should always be something that we want to look into. DEXA, dual energy X-ray absorptometry. Absorptometry. I can't even say the radiology words myself, so don't feel bad if you mess them up. It's the gold standard. They give you like a T-score. So -1 to -2.5 is osteopenia. Greater than -2.5 is osteoporosis. First line treatment, bisphosphonates. Yeah. And then I think the thing you'll see commonly in clinical practice is like Prolia shots. Okay.